A very good morning to everyone who made it to our webinar on this beautiful Sunday. It is such a pleasure to bring you all another captivating webinar from Strand Life Sciences. We are treading into a discussion on the role of genetics in epilepsy. In the last 2 decades, tremendous strides have been made in unraveling the pivotal role that genetics plays in epilepsy. There have been many, such as the discovery of the importance of de novo mutations, the complexities of genotype-phenotype correlations, etc. It becomes of grave importance that we empower our medical community with continued awareness and knowledge. And for this very purpose, let me introduce our highly renowned speaker for today, Dr. Vykunta Raju. He is a pediatric neurologist with over 23 years of experience in the field. He is a professor of pediatric neurology at Indira Gandhi Institute of Child Health in Bangalore, India. His main areas of interest are pediatric epilepsy, neuroinfections and para-infectious disorders, developmental neurology, and cerebral palsy. He received his DM in Paediatric Neurology from All India Institute of Medical Sciences, New Delhi. He has more than 160 publications to his name in PubMed index journals, over 70 publications in other index journals, and more than 310 abstracts in national and international conferences. He is a member of various organizations. He is an author and editor of the book on cerebral palsy and early stimulation, and has authored more than 25 chapters in various other textbooks. He is serving as an editorial member and reviewer of several reputed journals. Good morning, Dr. Vykunta Raju. We are honored to have you here today.
Good morning. So, shall I start?
Yes, sir, we can commence with the session. You can share your screen now, please.
So, thanks for giving the opportunity to speak on this topic today. So, I'll be going directly to the subject. So, this is the outline of my presentation. I'm giving brief introduction about genetics and also followed by various genetic type of testing and also what are indication and type. So, as you know, the epilepsy is the most common neurological disorders, especially in children, and it has various genes are described. As you know, that the improvement in the genetic testing yielded many etiologies for these various syndromes, especially in the pediatric age group. As you know, the advances in the whole exome sequencing has made epilepsy diagnosed very easy. And also, as the cost of the tests are decreased and also importance of various genes are improved, so it is nowadays used regularly in daily clinical practice. So to understand epilepsy, so this is a highly classification of epilepsy. So to properly understand my talk, so you should understand the epilepsy, the basics, etiology, and also the how to diagnose. So whenever you diagnose epilepsy, diagnosing itself will not stop. We should always try to find out the reason for epilepsy. So it gives important clues for management, also prognostication of the children. So this is a recent classification of ILE. It shows that always when you are diagnosed any case with epilepsy, in order to other than diagnose epilepsy syndrome or onset of epilepsy seizure types, you should always try to find out the etiology for epilepsy syndrome. The most common etiology in developing countries is usually acquired causes, but we know that most of the time we'll miss the genetic causes. So genetic causes especially plays an important role. In these subcategories, there may be an overlap like structural, genetic, and metabolic causes. All can come under genetic etiologies. So for example, structural like, for example, tuberous sclerosis and various congenital malformation of brain can have a genetic etiology. And also similar the genetic etiologies, various genes I'll be discussing, that also comes from genetic cause. And various metabolic syndromes, especially in children, they can present as epilepsy alone. So even though there are 6 categories, genetic is a one category, but the structural and metabolic causes can be a mixture of these etiologies, and also some of the unknown genes are not described. So in this category, most of these comes under genetic, except infections. I'm not going to details about this slide. So this is over the last 2 decades, the advancement in the genetics initially described gene for SCN1 for Dravet syndrome, followed by almost the targeted gene therapy for some of the epilepsy syndromes also. So this is a diagram showing that most common cause for genetic epilepsy is usually polygenic and oligogenic. So I will not be discussing these things because it is very complex one. And most commonly, what you are discussing is Mendelian inheritance, various subcategories of inheritance, and also non-Mendelian inheritance like chromosomal malformation and also mitochondrial disorders. So as you know that this is a genetic epilepsy, there is interplay between each, not only the malformation and genetic, there will overlap sometimes. The trauma may be an initiating factor that can predispose or it can increase the risk of epilepsy, those who are underlying genetic etiology. So there will be an overlap between one and other. And this is regarding the history. This is a flow chart showing that the percentage of unknown causes for epilepsy in 1975 and compared to last few years back, you can see that earlier we used to call most of them idiopathic without knowing any etiology. And over the period of 3 to 4 decades, you can able to identify causes for various epilepsy syndromes. So nowadays, you should try to find out the various etiologies for these epilepsy syndromes. So coming to the approach, so whenever evaluating the child with epilepsy, you should always try to get the details of all the clinical features in the child, especially the family history and pedigree is very important. And especially details of age of onset, various clinical signs, symptoms, and other system involvement, including the various laboratory testing like imaging and also metabolic profile should be analyzed to get the proper phenotyping. And followed by genetic testing. Before ordering the genetic test, you should have proper these not only clinical and also other test results also helpful for selecting the type of test and also to get the proper exact syndrome what you are suspecting. Once you order the genetic test, so you should also know what is the genetic test you are ordering or what is the type of technique they are employed and limitation of the test. I'll be giving some of the example for this. And especially in the presence of family history, it is always important to get the 3-degree family generation history that gives important clue for the diagnosis. So before labeling a genetic test, you should always identify some of the causes that are reversible, especially nutritional and environmental factors should be identified and should be excluded before labeling a genetic causes. So I'll be discussing some of the P-degrees. So this is the P-degree showing the most common etiology for epilepsy, most common inheritance of epilepsy. So this indicates only one child is affected. This is a common situation you will get commonly. Most common example, like maybe in a Dravet syndrome. So where if you tell parents that the child is affected with genetic epilepsy, most of the time they'll immediately reflect that no, the family is affected with genetic testing. Why are you doing genetic test for our child? So you should explain in details. Even though family members are not affected, there may be a de novo mutation. There may be a chance of recurrence. This type of pedigree can be seen in autosomal recessive inheritance also because consanguineous marriages are common in this part of the world and maybe they are just carriers only, so may not manifest disease. So the absence of disease in the family does not exclude autosomal recessive inheritance also. So in this, most of the times, especially Dravet syndrome, they can present like this, and also many developmental epileptic encephalopathy, especially in the first 1 or 2 years, they can present like this without any family history. So absence of family history does not suggest it's not a genetic cause. So this is a P-degree showing that most commonly described early on described as the SC1A mutation. So next few more slides, I'll be explaining what is the difference between genotype and phenotype. So when you are identifying the genotype with SCN1, it will not stop like that only. You should always phenotypically characterize what exactly the child is be having. So just the SCN same gene can produce like some of the non-epileptic events, sometimes Dravet syndrome, sometimes benign epilepsy also like Pibble seizures plus. So you should always try to fit into a gene of phenotype before giving the counseling because it can produce various phenotype also. So just identifying gene and telling that just SCN is found and you cannot tell it is Dravet syndrome and it is a bad prognosis. You should always try to fit into phenotype also. So as he told, this SC1 can present various phenotype, not only epilepsy, non-epileptic condition also. And this is a diagram showed that the clinical features varies from mild to severe also. The severe spectrum can present with like Dravet syndrome or even Otara syndrome in the early newborn period, and milder form like GFS also. So gain of function also present very early infantile developmental epileptic encephalopathy. So based on which genotype we can sometimes predict. So same genotype can cause various phenotypes. You should try to fit in the phenotype along with the genotype also. The most common, next common is complex inheritance possibilities. The multiple members of family can be affected without any specific inheritance may vary. Here epigenetics may play a role here. So most of the times it cannot be explainable. Less common is autosomal dominant inheritance. Especially it is important, especially in the younger age group, especially newborn period and also early infancy. Most of the idiopathic benign epilepsy syndromes can present like this. So where they should have been forgotten the family history in the grandparents and parents also, unless if you don't ask the history in the grandparents, whether the children's, their children, the parents have similar history in the newborn period, especially the dominant familial benign epilepsy syndrome, they should have been forgotten because these syndromes will subside as they grow. Usually they can present in the infancy alone. So detailed history, not only parents, sometimes grandparents helps in diagnosing mode of inheritance. This is a pedigree showing that the most common benign familial epilepsy in the newborn period, that is because of KCNQ mutation. They can have multiple members in the family can affected with the autosomal dominant mode of inheritance. So especially the history from the grandparents gives important clue that early diagnosis helps in prognostication and also limiting the number of investigation and also selecting the drug of choice. This is a similar autosomal dominant. So especially the vertical mode of inheritance gives important clue for the diagnosis. The other problem in autosomal dominant is various expression, also genotype phenotype correlation. This is one more example for other epilepsy syndrome that can present with epilepsy and also non-epileptic manifestation. One of the example, GLUT1 deficiency. You can see here that GLUT1 deficiency, you know that classical presentation is later part of the infancy with seizures or early onset absence seizure, or they can have myoclonic astatic epilepsy also. So in the same family, the multiple members can have different phenotypes. So you should always ask in detail what is the exact phenotype of the epilepsy. So red indicates usually these children are the myoclonic astatic epilepsy, but yellow indicates that generalized epilepsy, and green indicates usually focal epilepsy, and purple indicates focal epilepsy, and green indicates early onset absence epilepsy. So even though the genotype is same, the manifestation can be different. They can present the various different types of epilepsies, and also I'm giving some of the non-epileptic phenotypic features also. This is the same GLUT1 deficiency in the same family. So they can present along with epilepsy, they can have present with proximal exercise-induced dystonia, especially in the older age group. So you should always ask in the family whenever epilepsy is there, especially the children, if they're suspecting GLUT1 deficiency, fasting seizure, especially in the early morning, along with ataxia, sometimes dystonia, especially in the older children and also parents and sometimes grandparents, they can have exercise-induced dyskinesia. Dystonia can be present. So detailed about not only epilepsy, non-epileptic neurological manifestations sometimes gives important clues. So this is a phenotype spectrum of this GLUT1 deficiency. Usually they can present it commonly with epilepsy, but later they can present, later age group, they can present a movement disorder. So that is important taking the family history. This is the same chart showing that various different manifestations. This is a diagram showing that so based on age of onset, the severity also varies. Earlier the onset, the severity of the disease is more, and later the onset, they can present only the exercise mild form dystonia alone. So this is one more epilepsy condition. You can see this is a video showing early part of the infancy, child is getting a seizure, and the same child also, this is a moment. and same child after 1 or 2 days. So this child, so everybody can see this is definitely first video and third video showing the seizure, focal and also multifocal seizure, but second one shows that child has choreathetosis also. So when this type of phenotype is there, most of the times you'll be confused with various neurological disorders. You'll be thinking of most of the times it's complex disorders. But this is a very classical described condition. So this phenotype you should always use. This is called infantile convulsion and choreathetosis because of PRRT mutations. So this same child can have different manifestation, not only the seizures. So choreathetosis can be there. So that is the importance of phenotyping any child. So you can ask specifically for this gene, that is PRR22 mutations, so that they can look and you can get the gene and they can diagnose. And diagnosis is very important because not only the infancy, they can develop in the family history, also they can give history of migraine, and sometimes they can give history of paroxysmal kinesiogenic dystonia in the older people, like in the adults and grandparents also. That history also usually helpful. This diagnosis is very important because so the selection of drugs is very specific, and also too many drugs and too many investigation can be avoided, especially the side effects of drugs can be limited. So you can select the specific drugs and also you can explain to the parent that it is a benign condition. So it will, it is age-related disorder, they will improve. So this is the same one more family. You can see that the complex inheritance in the same family, they can have epilepsy, and also the star indicates paroxysmal kinesiogenic choreathetosis. So history of similar epilepsy and also chorea indicates this is a common cause for epilepsy. And again, the same gene can present migraine also. So partial seizures in the infancy, hemiplegic migraine also. So in the family history, along with epilepsy, if there is involuntary movement and migraine, you should always think this condition, especially in the child, is development is normal. Again, one more chart showing that they can present the various other neurological manifestations, like not only epilepsy, episodic attacks in the same member of the family. Sometimes the genes can be in a coincidence that may be in modifiers, like in the deletion. Some of them may have manifestation, some of them may not be manifestation. You should always try to correlate. Some of the genes earlier described, they can have pedigree that describe classical penetrance, like the X-linked dominant disorders, where the only females are affected. This is one of the early gene described with epilepsy, especially female children in the age group of infancy and early part of the infancy. Along with epilepsy, they can have artistic features. So only if the females are affected in the family, you should always consider this is one of the gene that is contributing for epilepsy. Similarly, some of the X-linked recessive disorders can present with epilepsy. So various genes are described. Most of the other common disorder, like cerebral creatine deficiency, commonly seen in the X-linked males. That also one of the one of the things you should consider whenever there is a X-linked inheritance is present in the epilepsy. So this is a flow chart showing that the various genes where they are described in the epilepsies. Most of the times are ion channel. They are commonly seen in properties including Dravet syndrome and also benign neonatal seizures, and also including the GABA mediated genes. Other group of disorders, synaptic vesicles, so and also mTOR pathways. So this is the various genes where the epilepsy is commonly described. So diagnosis is very important because sometimes the phenotyping is easy, and also you should ask for specific disorder, specific disease you are thinking, so that you will get proper genetic testing. This is a flowchart just showing that various genes for epilepsy and the situation in the chromosomes. No need to remember that one. So why genetic test should be done? Basically to choose the specific treatment. Genetic testing, which test should be done order before advising any test for the patient. So there were basically two types of tests, cytogenetics and molecular genetics. So cytogenetics in this category, karyotyping and microarray and sometimes fish. Karyotyping is rarely used nowadays, especially only if you are suspecting like ring chromosome sometimes cause severe refractory epilepsy and non-convulsive status epilepticus that can be considered whenever unexplained cause for epilepsy with especially non-convulsive status or epilepsy syndrome with subtle dysmorphic features. Microarray is the one that if you are suspecting multiple congenital anomalies along with epilepsy, you should order for microarray. Fish is ordered when, especially if you are suspecting specific phenotype like Prader-Willi or Angelman syndrome. Angelman syndromes can present a refractory epilepsy, so that time we can order specifically for these tests. Otherwise, if there is no specific clinical features, you should order for exome sequencing by NGS. So this test selection based on our experience and also availability, gene panel will be considered whenever you're suspecting specific group of disorder. If you're not able to fit into any specific group of disorder, you should go for whole exome sequencing. Till that you are up to that mark also you are not able to find out, then whole genome can be considered if you are exhausted with all other investigations. So this is some of the advantages and disadvantages of various tests. So I already explained. So usually most of the times this table is useful when you are selecting the test. The most commonly used test is whole exome sequencing, unless if you have specific markers in the clinical examination says that specific disease you are suspecting, then you can consider these other tests. The exam sequencing also, I should specifically ask which one you are asking. There are some advantages and disadvantages. So as I already told, if you are suspecting specific gene, you can ask for gene panel, otherwise whole exam. So this I already explained. So the microarray is useful, especially if we are suspecting some subtle dysmorphic features and multiple congenital anomalies. And always you should confirm with whatever comes positive in exam sequence, Sanger sequencing. And advantage of next generation sequencing, they will screen multiple genes at a time. That is especially cost effective if you are not clear about what gene you are suspecting. This is again same table, some of the common mutations and genotype and phenotype correlation. I'm not going to details. These are some of the earlier genes with various epilepsy syndrome that are described. So coming to the management with these epilepsy syndromes. So earlier conventional epilepsy syndrome management is earlier whenever child comes with epilepsy, you used to give any medication based on phenotype, like whether it is focal or generalized. So the effect will be only 50%. It may they may respond, they may not respond. But currently with advancement in the genetic testing, you can do a genetic testing, you can identify the genes. So the effect will be better compared to the conventional treatments. You'll get a better effect. I'll be giving some of the examples. Some of the precision medicine are like some of the times vitamins can be used, sometimes nutritional, sometimes diets, sometimes may require surgery also. This is some of the conditions. Especially they will present with the epilepsy. I selected only those things that present with epilepsy, like most commonly pyridoxine dependent seizure. So you should always suspect, especially the seizures onset in the intrauterine life and also refractory neonatal seizure. You should always consider pyridoxine dependency, especially with other investigations normal, except if you have done specifically the CSF analysis for pipefolic acid. We should always consider this treatable condition, and especially you should not miss whenever there is a family history. Similar to that pyridoxal phosphate dependency, they will respond for pyridoxal phosphate. They will present similar to pyridoxine dependency. Usually the biochemical tests for these three subcategories are not able to differentiate pyridoxal phosphate and polynicol responsive. So the one that differentiates genetic testing, so that is usefulness in genetic test. Other is non-ketotic hyperglycemia, sulfate oxidase deficiency, molybdenum copacity. They are partially treatable. I'll be giving a treatment, and defect in serine biogenesis. And glutathione deficiency, ketogenic diet, where it is useful and established also. And similarly, ketogenic diet can be used in pyruvate dehydrogenase deficiency. And this is a treatment and dosages. I'll not be going to details. So the creatine deficiency, other syndrome I will be describing. So they can present creatine supplement, and also serine biogenesis defect. They can improve with serine supplements. Some of the other condition along with epilepsy, they can have other manifestations like development delay and other manifestations. Some of them are vitamin deficiency. It should be considered always child with a refractory epilepsy, especially spasms, along with skin changes and cerebral palate. They can present a refractory seizure along with ataxia. NKH I already discussed. Some of the other IEMs they can present with epilepsy alone, where formula date should be considered. These are some of the vitamins that are useful, like thiamine is useful in mitochondrial disorders, especially in maple syrup urine disease and pyruvate dehydrogenase deficiency. Riboflavin in glutaric aciduria 1 and 2. Pyridoxine is other than pyridoxine dependency that can be used in molybdenum cofactor deficiency and also homocystinuria. Betel especially useful in various metabolic conditions that present predominantly with epilepsy. Polinic acid, I'll be giving some of the example, and biotin also. So some of the other epilepsy that have a specific treatment described as tuberous sclerosis, where rigabatin should be considered, especially in the early infancy. mTOR inhibitors should be considered if there are refractory epilepsy, and also long-term beneficial effect of metformin also described. And KCNQ mutation, especially KCNQ2 and KCN3, they can present with the refractory seizures sometimes in newborn period, and they respond with oxcarbazepine, carbamazepine, and pitagabine. So it should be these drugs should be considered. And KCN2 mutation, even though the response is less, but they can try with quinidine. And SCN1, you should always avoid sodium channel blockers. You should select a specific drug like stiripentol if it is available, or valproate, clobazam, and CBD oil. And if you are detected SCN2 and 8A, especially gain of function mutation, you should always consider sodium channel blocker. They are very useful. And some of the specific genes like STXB1, they will respond better with levetiracetam compared to other drugs. And green 2A mutation, you can consider memantine that may be useful sometimes. And other genes that PRRT2 I was describing, usually they will respond with a single drug like sodium channel blocker like carbamazepine or valproate or phenytoin. And some of the other genes like CDKL5 and PCDH19, they can respond partially with ganoxylene. And recently the antisense oligonucleotide and gene therapy is still in research. They may be useful in the future if you diagnose specific condition. As already described, the SCN1 and SCN2, you can select the type of drugs. The role of testing in genetic testing in benign epilepsy syndrome is also very important, especially those presenting in the newborn period in early infancy. Even though they're benign, initially it is difficult to diagnose. They will present with a cluster of seizure with sometimes refractory requiring 2 to 3 anti-seizure medication requiring admission for 2-3 times. So usually, most of the times we will diagnose these conditions retrospective after treatment with multiple anti-seizure medication with a lot of side effects without proper counseling. So whenever suspecting benign epilepsy syndrome, genetic testing is especially useful. So these are various commonly described, commonly found out genes with the benign epilepsy syndrome, those onset in newborn period, infancy, and also in the early childhood. So most common is PRR2 and KCNQ. So diagnosis is very important. These conditions, genetic confirmation is important, gives important clue for selecting the type of drugs instead of giving highly toxic drugs, and sometimes it limits the duration of seizure treatment also. If you know the diagnosis genetically, so you can counsel that you can decrease the duration of treatment also, and drug of choice can be selected, even though it is benign. And genetic testing is also useful to select the drugs to avoid the side effects. One of the common thing is Steven-Johnson syndrome. HLA typing is useful so that it predicts who will develop, even though it is not well established HLA type, but some HLA subtypes are known to cause epilepsy, Steven-Johnson syndrome, so you can avoid. So coming to our experience with these epilepsy syndromes. So this is one of the case scenario. This child presented refractory multifocal seizure from newborn period. Child also has hypotonia, encephalopathy, sepsis outcome was normal. So this is the EEG showing that burst suppression pattern, and MRI showing the only finding is corpus callosum hypoplasia, and the TMS, HPLC in the CSF, and the CSF shows increased glycine ratio that indicates the NKH, and other routine tests usually will be normal, especially the routine metabolic test like ABG, lactate, ammonia, TMS will be normal. Only the CSF analysis by HPLC method like glycine is useful to identify this condition, and this is confirmed by genetic testing. So this confirmation is very important, especially the counseling for the next pregnancy, and also give the long-term prognosis also. Sometimes non-genetic condition they can present with epilepsy, refractory. This is a child with movement disorder presented with treated as a refractory epilepsy, even though this child has no epilepsy. So this child is improved just specific treatment for this rare condition. So other some of the phenotype, genotype difficulties, what you'll see routine practice I'll be describing. This is a 2 case scenarios presenting a newborn period. So both are present in the first week of life with multifocal seizures, not only the focal, multifocal, and also myoclonic jerks. Both of them are encephalopathy. The routine metabolic tests like ABG, lactate, ammonia, TMS, GCMS, including neuroimaging, all are normal. This is EEG showing a burst suppression pattern, both similar pattern. And one child has a non-ketotic hyperglycemia, other child is a pyridoxine dependence epilepsy. So both will present usually the similar phenotype, but the diagnosis is entirely different. This can be done usually biochemical test with more difficulty. Sometimes they can be normal also, because availability of these biochemical tests is difficult. So genetic is the one that gives the definite diagnosis that is required for genetic testing also. So one will improve usually with the simple betal supplement, other may have a bad prognosis. So this is the important genetic testing where phenotype may be in a similar, genotype is useful. So pyridoxine dependency, the genetic test is very useful other than biochemical tests. Sometimes biochemical tests may not give accurate diagnosis. It may be false positive or false negative. As I told, they may not be available routine in all the places. Cost also expensive because you need to do testing both in the CSF, serum, and urine testing also. So instead of test, genetic test gives important clues. So this condition should be considered whenever unexplained epilepsy, especially in the newborn period, because various families, you can see this is a family showing that many siblings are affected, died within the first 6 months of life before diagnosing the index case. So it should be not be happened because of non-availability of these genetic testing. One more similar genotype and phenotype correlations. So again, these 2 children present epilepsy in the seizure, multiple refractory seizure in the first week of life. Both have multiple phenotype requiring multiple anti-seizure medication. Some differences are this, there is a family history of epilepsy in this child, but there is no family history. This is overlap. There is no family in this girl, but there is a family history in this. So routine test is normal, but genetic test confirm that both children have the same mutation, like KCNQ mutation. So the KCNQ mutation is known to produce benign neonatal epilepsy syndrome, and also benign, also it produces malignant epilepsy syndrome, like that is Otara syndrome, or earlier used to call early myoclonic epilepsy, and early infantile epileptic encephalopathy, that is called now early onset developmental epileptic encephalopathy. So gene is produced the same. The only factor that differentiates these two conditions is one is autosomal dominant mode of inheritance, that is in a benign variant where the both parents are as you are already told, I have shown in some of the pedigrees, the parents are affected. So it is inherited by autosomal dominant mode. So they will improve usually benign condition where it is de novo mutation. There is no family history in this. So de novo mutation causing a severe epileptic encephalopathy in the later age group. Again, this genetic testing is useful. Some of the condition where we can earlier used to treat the refractory epilepsy or because of cerebral palsy. So this is a child with the present refractory epilepsy from the newborn period and requiring multiple anti-seizure medication, but without that there is no improvement. Clinically, child has a spasticity and all features may be suggestive of cerebral palsy. But as a pedigree shows that the 4 siblings are affected with similar condition, but you cannot label it in a cerebral palsy. And even imaging in this child shows like a cystic encephalomalacia. So usually previous 2-3 siblings treated in a cerebral palsy, but without any improvement. But some of the other clues, you can see that this child has dysmorphic features, allotemporal fossa, and also the boggy cheeks. And the routine test was normal, except the detailed clinical examination shows lens dislocation and uric acid level was very low. And ultrasound showed the uric acid stone. This MRI resembling like a cerebral palsy. And genetic test shows that is a malignant cofactor deficiency. The diagnosis in this child is important. The child, next child is born with a normal child after diagnosing genetically with in the antenatal period. So this child basically present refractory epilepsy because of metabolic condition. Some of the metabolic conditions they can present with the epilepsy alone, especially in the newborn period. So you should always consider the genetic causes for these epilepsies. This I already described. So in the newborn period, especially you should consider genetic causes, especially the seizure beginning in the intrauterine life, especially, and also early infancy, other than HI after ruling out HI, and they are not responding for routine anti-seizure medication. And there is a worsening of clinical and EEG abnormalities, especially EEG showing hypsarrhythmia, burst suppression pattern, and MRI may or may not give us important clue for the diagnosis. You should always consider this condition. So after doing a routine metabolic test, if you are not able to find out any metabolic abnormalities, you should always consider developmental epileptic encephalopathy, especially secondary to genetic etiology. So this is a flow chart that usually will follow most of the times. Whenever a child with neonatal seizures not responding for regular medication like phenobarbital, levetiracetam, you should always consider pyridoxine dependency. You should always try with pyridoxine. If there is a response, you will label the pyridoxine dependency. If there is no response, you should try pyridoxyl phosphate. If there is a response, you will label the pyridoxine phosphate. If there is no response, you should try polinic acid. Then you label the polinic acid response. This is a flow chart usually most of the times you'll follow when they present refractory seizure, especially in the first 6 months of life. This I already described. This is one more child usually used to work up earlier days before genetic testing. Used to do many tests. This is just an example to show how difficult before genetic tests. This child presented around 1 year of age with multiple types of seizure from early infancy, multiple semiology, and there is a mild delay initially followed by regression. This is various family members affected. 2 siblings are expired because of similar complaint around 4 to 5 years of age with refractory seizures and developmental delay, not able to diagnose. This index case also came with developmental delay with refractory epilepsy. Most of the drugs are tried available those days, and there is no significant response, including what we usually try with pyridoxine polinic acid biotin also. So examination showed that only some malnutrition and also microcephaly, and these are various disorders I already discussed. These are various disorders you will consider whenever there is a refractory epilepsy development delay without any apparent cause. So you are consider all these conditions, and most of the things are done to rule out these tests. The routine investigation does not reveal any specific abnormalities, and including metabolic tests, including lactate ammonia, TMS, GCMS was normal. EEG showing only burst suppression pattern, MRI only showing non-specific cerebral atrophy, and including your thought of NCL, that is more sometimes present early infantile refractory seizures, and you were done enzyme SC for that also, and also including invasive tests like bone marrow biopsy to look for storage cells, skin biopsy to look for NCL, and muscle biopsy to look for mitochondrial discharge. So you used to do so many investigation, including invasive tests to diagnose these disorders, but simple tests like a glucose test, CSF glucose test gives important clue. This child is a persistent 2 values, 2 times you are done at least 1 week, 3 to 4 days apart. It shows that the glucose is less and there are no cells. It indicates GLUT1 deficiency, and started a ketogenic diet and child was improved. So So this genetic tests make easy that you can avoid many expensive and also invasive tests currently. So nowadays you will go for directly the genetic testing instead of doing so many tests. That is the important of genetic testing. Again, the phenotype, genotype, you should always correlate. Usually phenotyping is very important. Sometimes you can find a new gene, but you should always go for a reverse phenotyping. If gene is discovered, if you're not able to find fit into phenotype, you should always search and you should go for reverse phenotype if you're not able to find out any specific genes. There's some of the epilepsies, especially from our institute. Some rare syndrome, like this is a child present with refractory epileptic spasm secondary to metabolic problem, brain defects. And this is, you are talking about pyridoxal phosphate dependency. So whatever textbook describe, usually they will respond pyridoxal phosphate alone, but this child has responded to the regular management like steroid. But child has completely seizure free after starting pyridoxal phosphate at 4 years, 2 years of age. And child is alone pyridoxal phosphate now. There's some of the metabolic condition. Again, they can present epileptic encephalopathies, and some rare syndromes gives important clue that can present with epilepsy syndrome that gives important clue. And cerebral folate deficiency, as I told, they can present epilepsy along with ataxia. And some of the epilepsy syndromes with the epilepsy rare syndromes nowadays commonly find out. Earlier days it was very rare. Some of the cobalamin defect disorders that can present epilepsy alone in addition to metabolic encephalopathy. And most common Dravet syndrome, that is the most common disorder. As I told, they can present not only Dravet syndrome, they can present in the early infancy like neonatal early infantile epileptic encephalopathy. Also, in addition to classical Dravet syndrome, there is variation in genotype, and they can present the West syndrome in addition to Dravet syndrome. And most common part of this part of the state is hot water epilepsy. There is a lot of genetic contributed genes are described. So you should always consider this as one of the cause for epilepsy, genetic cause for epilepsy. And whenever there is along with this epilepsy, if you have any refractory infections, especially pancytopenia, you should always consider hereditary folate malabsorption. And this is a group of progressive neurodegenerative disorder. They can present only as a refractory epilepsy, like an NCL. So you should always consider, along with refractory epilepsy, myoclonic epilepsy, you should, with the ataxia, you should always consider NCL. That is the most commonest cause for progressive myoclonic epilepsy in children, neurodegenerative disorder. Sometimes rare leukodystrophy, this child present refractory epileptic spasm, Alexander disease. And this is gene you show that in this also you are related a lot of epilepsy syndromes along with other genetic conditions. As I told, some storage disorder they can present with refractory. This is a child present exactly only as a refractory seizure initially with artistic regression rather than classical presentation. So as I told, glutathione deficiency, this child presented in the later age group ataxia rather than epilepsy. This child usually has only early morning ataxia, fasting ataxia. So this is one of the very earliest case I shown case summary. This is one of the earliest case reported from India with glutathione deficiency. This is a cohort multicentric study done from most of the major hospitals from India, West syndrome cohort. It shows that the various genes are responsible for West syndrome, not only the specific genes. So it shows the heterogeneity of genetic disorder for this epilepsy syndrome. But this study shows some of the clinical features gives important clues when you should consider genetic testing for epilepsy, especially West syndrome, like along with epilepsy episode, central hypotonia, microcephaly, dysmorphic feature art testing, we should consider genetic testing for S syndrome. And the conclusion from this cohort is the genetic etiology, as I told, it is it is heterogeneous, where multiple genes are described. Most common is pyridoxine dependency and Down syndrome, and some clinical features I already described. So to summarize, the whole exam sequence, it is more easily accessible nowadays because of improvement in the technique and also decrease in the cost and importance of yield of these tests. And as the days goes, it may be easily available in most of the places. To conclude, the phenotyping, clinical phenotyping is very important when you're asking for genetic testing. Not only the malignant epilepsy syndrome, the benign epilepsy syndrome also is useful, especially to select the drug of choice and also decrease the duration of anti-seizure medication and also anxiety for the parents, and also it gives more satisfaction for treating doctors also. And in the malignant cases, especially the diagnosis is very important for counseling and also prevention of the recurrence. And moreover, some of the example I told, the precision medicine is currently available. Thank you.
Thank you so much, Dr. Vykunta Raju. That was a very extensive and very inspiring session and a learning experience. So we can start off with the question and answers now.
Yeah.
Okay. Currently, I'll ask this. If the couple confirmed with family history of genetic disorder, hope before planning a kid, the couple can go for carrier screening so they can avoid genetic disorder offspring.
Yeah, that is possible currently. You can go for it. That is possible.
Okay. There's a question. How big of a role does diet play in the management of epilepsy?
Diet in general, usually the ketogenic diet is used in many epilepsies and any refractory epilepsy, they are not responding for anti-seizure medication. Ketogenic diet is one of the mode of treatment for epilepsy, but some condition like as we described, glutamate deficiency syndrome, pyruvate dehydrogenase deficiency, some of the other rare metabolic condition where ketogenic diet is useful, that is a drug of choice you can consider. Some of the metabolic conditions can cause epilepsy. I have not gone into details like some urea cycle disorder, MSUD. Those can also produce a refractory epilepsy where they may require specific dietary formulas, supplement, special diets are required. So in this way, the diet plays important role in epilepsy management.
Okay, sir. Thank you. Where do you use vigabatrin? In which indication?
Vigabatrin is used as a drug of choice whenever a child with tuberous sclerosis, that is a genetic condition with epileptic spasm, that is a drug of choice you should always consider before using other drugs. Nowadays, that is used as a prophylactic also before starting spasms. And any child with epileptic spasm not responding with first-line drugs like steroids, vigabatrin is a second drug of choice. And rarely it can be used as a focal seizure. There are refractory to the currently available drugs that can also be used in vigabatrin. So these are some of the indications for vigabatrin.
Okay, sir. Thank you. Okay. If you find a VUS with incomplete penetrance, how do you go about the classification and further diagnosis?
Yeah, VES, if based on gene and also family, if VES is a clinical phenotype is fitting, we can do some other tests like biochemical, other functional tests. So it will fit into the same genotype or not. And it can also, family segregation studies can be done, like testing Sanger sequencing the other siblings, also parents. That gives important clue whether it is just a VES or it is really pathogenic. So family segregation studies and also other functional studies, and also if the other clinic type it is fitting, we can consider it as a significant.
Okay, sir. Thank you. Do you use a standard turnaround time or expedite NGS in case of epilepsy in ICU and in OPD?
So currently the cost is a factor. If they're affordable, you'll go for fast train. Otherwise, routinely it takes 3 to 4 weeks. So based on affordability, you should decide.
Okay. 6-month-old normal birth and development with clusters of seizures with mother, similar history, and mother asymptomatic by 2 years. What is the most likely gene? Metabolic screen. What is the most likely gene? Metabolic screen is normal.
The most commonly described, I already told PRR2 mutation. That is the most common benign epilepsy gene described. That is the most commonest one.
Okay. What are the challenges of therapeutic management in case of epileptic encephalopathies?
Yeah, there are many challenges. As I told, you should try to fit into any treatable condition. You should identify. If not identified, you should always, if the epileptic encephalopathy is there, you should always give steroid. If it is not if refractory, you can try spasms or vigabatrin. And other drugs are rarely useful. Sometimes you should always try with ketogenic diet also. And even though after excluding metabolic causes, valproate can be tried. And some of the newer drugs that are not approved, after taking consent from the parent, you can consider. And this is a challenge. Most of them, they are refractory, especially the developmental epileptic encephalopathy, but they will improve over a period of time with little bit only. But you should counsel for the parents that they should accept the disease and also the long-term sequelae.
Okay, sir. Thank you. How to decide which genetic test needs to be sent in for epileptic encephalopathy?
Epileptic encephalopathy, as I told, if you are not clear from your clinical clues that which one you are suspecting after doing a regular testing, according to me, you can, if facilities are gene panel, if you are suspecting any specific gene, only epilepsy per suspect gene panel is okay. If you are not sure it is an epilepsy syndrome or it is a metabolic condition or some other condition, you can go for whole exome sequencing.
Okay, sir. Thank you. Is GB data of whole exome sequencing effects for epilepsy?
Yeah, definitely.
How to prepare ketogenic diet for children?
Yeah, children, there are usually earlier days used to give, you should calculate the diet based on child's age. Usually younger age, you will give a lesser ratio like 3:1 or 2:1. And the older children, you can consider higher ratio like 4:1. So after calculating how much requirement of protein, fat, and carbohydrate, based on baby's weight, you should calculate each day meal, and afterwards you should divide in 4 to 5 meals. So you should explain each recipe, what are the contents. Nowadays, ready-made formula, special diet formulas also there, but only thing they are very expensive. But parents are educated, they can explain how to prepare the homemade ketogenic recipes also.
What metabolic disorder need to be ruled out before starting valproate in epileptic encephalopathies in the ICU?
The ICU, basically, we can't completely rule out testing, at least basic tests like you should do LFT, liver function test, and ammonia, and lactate, and TMS, GCM. That gives, you can exclude most of the common metabolic disorders, but totally we cannot exclude 100% without clinical phenotypic genotyping. But this is the basic screening test so that you can relatively exclude these disorders like mitochondrial urocycle disorders that can present a metabolic encephalopathy. So the basic screening test, ABG, lactate, ammonia, LFT, and TMS, GCMS usually relatively rules out these are not 100%.
Okay, sir. Thank you. When child is on multiple AED in super refractory epilepsy, how exactly to taper AED? Is it like the drug we started first? Should we taper it first?
That depends on super refractory, whether the child is an ICU or with a in home treatment, either super drug-resistant epilepsy or it is an ICU setup. So that depends on many factors. You should consider the child responded for which drug, and also you should consider side effect with the medication. So the child not responding, or if you're feeling the interaction is more, that drug should be decreased. If side effects are also more, those child responding for drug, that you can be retained.
Okay, sir. Thank you. How common is mitochondrial DNA inherited epilepsy? What is your experience in this regard? When do you consider mitochondrial exome in pure epilepsy phenotype?
So mitochondrial disorder usually presenting with the epilepsy alone is very rare. Usually they will present with the other phenotype. Usually they will present with especially usually in children, the most common phenotype is mitochondrial depletion syndrome, leak syndrome, or these are, but rarely you can get MELAS and MURP in the older children. are especially plaque mutation. They can present with refractory epilepsy with liver involvement, without the liver involvement. So plaque mutation is one they can present the refractory epilepsy. We should always consider plaque mutation. So other conditions rarely present with epilepsy alone. So this that is plaque, there is Alport syndrome should be considered whenever there is a refractory epilepsy, and it should be ruled out.
Okay, sir. Concluding today's webinar session, on behalf of Strand Life Sciences, I would like to express my heartfelt gratitude to everyone who made this webinar possible on a Sunday. And we are very thankful to Dr. Vykunta Raju for sharing a glimpse of his immense knowledge with us today. So do you have any closing lines?
No, thanks for attending lecture. So for all of them, thank you.
Thank you so much. Everyone have a great Sunday ahead. Thank you.
Thank you.